Hello.
Hello, dear. How are you?
Hello.
Ron, John, Liza,
Hello, guys.
George,
Hola. Hola.
Becky,
Hola, ¿qué
Isabel,
tal?
Hello. How are you?
Valentina, Lieber
Hello.
Jürgen, Annabelle, Carmen, our dear Richard Stasny, Adi, Teresa, Peter Juli.
Joseph.
Hi, Eugenie.
Hello,
Very good, sir.
Joseph. Lieber Joseph, Carolina, Giovanna Cantarella, ciao. Rosa Maria, hola. Marco Fantini, ciao. Sarah Harris, very nice to hear you.
Hola.
Hello. And this is a
Ah,
great.
Luis.
Hello, Luis.
Hola.
Hello, everybody. It's wonderful to see you, to hear you. And we are beginning our third CoMeT session. Hello, Sarah, Tom, Harris. Nice to see you. And as you know, this is our third online CoMeT academic session. And it is a great pleasure to have you here with us today in this wonderful 12th December. And we shall enjoy our CoMeT members' presentations. The first presentation is from our dear CoMeT member, Isabel García López. As you know, she is an ENT and phonosurgeon, laryngologist mainly, from Hospital Madrid La Paz in Madrid, Spain. Very welcome to this wonderful work that she is presenting about neurogenic lesions in professional singers. Thank you very much for your work, dear Isabel.
Are you recording, Eugenia?
Yes.
Good evening. This is Isabel García López, laryngologist from Madrid, Spain. The first thing I want to say is to thank you to Eugenia and to all the board of the CoMeT. I'm very happy to be here sharing with you this presentation. And today I'm going to talk about neurogenic lesions in professional singers. The first thing I want to say is, as you probably know, is that vocal fold paralysis is not the same thing as vocal fold immobility. And in fact, the difference is made by the presence of neurogenic lesion in the case of vocal fold paralysis. Between vocal fold paralysis, the complete immobility of the vocal folds, and normal mobility of the larynx, there are also many situations that sometimes are quite difficult or challenging to evaluate. And neurogenic lesions are not related with professional voice use, and vocal fold paresis, one of these intermediate situations between the normal mobility and the paralysis, is many times a challenging diagnosis, and it has to be confirmed by the laryngeal EMG. The objective of this work is to describe the presence of neurogenic lesions of the larynx in professional singers, and also to describe the clinical characteristics and the management in this specific group of population. We made a retrospective review of the clinical charts of the last 10 years, the charts of all the professional singers that came to our clinic with the following inclusion criteria. The presence of a vocal fold paralysis diagnosed by endoscopic immobility of one or two or both vocal folds, or the presence of vocal fold paresis, also diagnosed or suspected by the presence of some endoscopic criteria. The criteria were the presence of hypomobility or asymmetry in the adduction, abduction, or elongation of the vocal folds, and the presence of unilateral supraglottic hyperfunction. Let me show you two examples. In this case, you are going to see an hypomobility of the right vocal fold at your left. There is mobility, but the range of adduction, abduction is not the same in the right vocal fold compared to the left. And in this other case, you are going to see the right, in the right vocal fold too, the supraglottic hyperfunction compared with the left one. And you will also see the presence of an asymmetry in the face of the mucosal wave. That is also a sign of suspicion of paresis. The laryngeal EMG was performed with the following protocol. We test both cricothyroid muscles in order to test the superior laryngeal nerve, and both thyroarytenoid muscles in order to test the recurrent laryngeal nerve. These are the items that we look for in the EMG: the presence of spontaneous activity, the morphologic characteristics of the motor unit action potentials, the recruitment pattern, and the presence of synkinesis. Let me show just you an example of spontaneous activity. These are the presence of denervation waves. This is the recruitment pattern with normal register compared with a lesion of the nerve. And this is the definition of synkinesis. This is the thyroarytenoid muscle, and you see the normal activation in phonation and the abnormal activation in inspiration in this muscle. These are our results. We had 447 professional singers. Most part of them were women. These are the styles of singing. 65% are opera singers, following by pop singers, musical theater, and 2% of flamenco singers. That is a Spanish musical style. Out of these 447 patients, 13 patients had the diagnosis of paralysis or paresis. We had just one case of vocal fold paralysis, and the other 12 were vocal fold paresis, based on this endoscopic sign, so 3% of the patients. The main symptoms of presentation were related with the singing voice. Just 2 patients had symptoms related with the speaking voice, and the main symptoms were difficulties with the upper register, also with the passaggio, with voice breaks in the passaggio, the presence of vocal fatigue, and difficulties in the pitch accuracy. Regarding the etiology, just one case which was related with thyroidectomy. This was the woman with the vocal fold paralysis, and the other 12 were idiopathic, and 11 had clearly the symptoms start clearly after a viral infection. Even though the laryngeal EMG was indicated in all the cases, only 5 out of the 13 patients decide to do the laryngeal EMG. And in these 5 cases, we found 3 cases of a lesion of unilateral lesion of the recurrent laryngeal nerve, and 2 cases of a lesion of the superior laryngeal nerve. The clinical evolution, one case has to leave the profession, was the woman with the paralysis, and the other 12 received voice therapy, and none underwent surgical treatment. Let me show you one case, one of our cases. He's a man of 39 years old, a baritone, solist opera singer. He refers clearly dysphonia of the singing voice after an upper respiratory infection with normal speaking voice, and he says he has difficulties in the upper register, the sensation of having a stiff voice in the upper register, and also breaks in the passaggio. When he came to our clinic, he had 2 previous diagnoses of LPR and of muscle tension dysphonia. And he's very worried about the problem because he has to, he knows that he can do these cancellations because he has to sing the main role in Traviata and Butterfly in the next months. Let me show you the voice of the patient. You will hear this break in the passaggio from the chest voice to the falsetto voice that is very clear to the ear. ¿vale? Intenta hacer en el pecho un poquito más, con un poco más presenciales. You hear this break that we can also see in the spectrogram here. When he goes up to the falsetto, he has his break in the voice. And this is the stroboscopy. You will see many things. You will see the different range of adduction, abduction of the right vocal fold compared to the left. You will see the different position of the arytenoids, and you also see the supraglottic asymmetry, more supraglottic contraction in this right side. And you will notice too the difficulty on do the falsetto, a great contraction, anterior-posterior supraglottic contraction in the falsetto voice. A lot of tension in the falsetto that he previously didn't have. This is the laryngeal EMG. This is one of the cases that accede to do the EMG. And you can see here the left cricothyroid register with the normal register compared to the right cricothyroid muscle that is clearly abnormal. So this means that our diagnosis is paresis of the right superior laryngeal nerve. In this case, the evolution, the patient received singing voice therapy during 6 months, and he had a complete recovery of the singing voice. I'm going to show you now the voice after these 6 months, and you will see how the break of the passaggio voice has disappeared. In conclusion, endoscopic diagnosis of vocal folds paresis remains controversial. Diagnosis has to be based on laryngeal EMG. Professional singers seem to have more idiopathic neurogenic lesions compared with the general population. Professional singers are many times, at least in Spain, reluctant to do laryngeal EMG, probably due to the risks inherent to the test, and laryngeal compensation appears to be prevalent in professional singers. Thank you very much.
Thank you very much, dear Isabel. This is a wonderful, wonderful presentation. And I would like to open the discussion. If you, Isabel, have something to add to our presentation, please, you have the word.
Oh, just to say again, thank you to all of you. And to point that this difficulty in the diagnosis of this pathology in professional singers, we are very used to do EMG in all our patients when we suspect this kind of lesions, but in singers, we are.
Okay, Isabel. Yeah. So I think this is a very important work, and we all are having problems with this kind of neurogenic problems. So if somebody has something to add, John, you wanted to say something? Yes, John.
Thank you very much, Eugenia. It was lovely work. Can we see that video again? what I was particularly interested in was if you look at the arytenoid on the right side, you see that it actually prolapses in. Now, my own personal experience, even if the EMG is normal, which it often is with a paresis, that when you see that prolapse of the arytenoid, it means that the PCA isn't being supplied adequately, which would suggest to me that there was probably an element of a recurrent laryngeal nerve palsy or paresis as well, even though it couldn't be identified on the EMG. And I don't know, Isabel, if you have that problem with EMG, because we do a fair number of EMGs. And for me, I often see patients who I'm convinced have a paresis, but the EMG doesn't prove it. And I think that's because there's still flow going through, even though it's not functional. Do you have a similar experience?
Yes. What I think also is that paresis is by definition a partial lesion of the nerve. So only some axons are damaged. So we routinely test cricothyroid and thyroarytenoid muscle, but we don't test, for instance, PCA, as you already said. So I think sometimes perhaps the axons that are damaged are, for instance, axons to PCA, and we cannot reach it. So perhaps this is also one reason why we cannot sometimes find a pathologic laryngeal EMG.
I think we can discuss after this session in order to prepare the video that you wanted to see again, John, because I think this is a very interesting discussion. And I don't know if somebody else from our dear audience, and I have to say hello to Andrea, Ricky, Macareni, and to Ilter, and I shall keep on saying welcome. Okay, Ilter, you wanted to say something.
Yes, hello everyone. Nice to see these beautiful faces. I'm happy to be one of this very high-level group. I would like to add one thing that should not be forgotten. The distal part of the recurrent nerve may sometimes get paralysis or paresis. So we can see an isolated thyroarytenoid paresis. The arytenoids move almost equal ranges, but the vocal folds, which is affected by this distal paresis, may be seen thinner, and the mucosa cannot make the high amplitude mucosal wave. So we may consider distal end thyroarytenoid paresis, and sometimes it's not easy to make the diagnosis.
Thank you very much. And I say hello to Carolina.
Hello.
Lieber Wolfram Seidner, our lieber, Joaquin, Marie-Dominique, our dear Iris from Argentina, Fatima. So we shall keep on working with our next presenter. And this is a very important work also that she has been working. This is Dr. Filipa La. She is a researcher from departments of didactics in the school and the school organization. And she's working for many years with the menopause. She's also in the special didactics of the University of National Distance Learning in Madrid, Spain. As you know, she was born in Portugal. So we welcome this very interesting part of her work, effects of menopause on voice metrics and patients, reported outcome measures. Filipa, very welcome.
Good afternoon, ladies and gentlemen. It is an honor and a pleasure to be here today with you, presenting the results of a study that I've done together with a colleague of mine, Diego Ardura, at the Faculty of Education of the National Education of Distance Learning in Madrid, UNED, where I am based now. A work that is a systematic review and meta-analysis on the effects of menopause on voice metrics. And I would like to start this presentation by saying a big thank you to Eugenia Chavez for this opportunity of being at the CoMeT meeting presenting the results of this work. So let's start. So the voice is a target for sex hormones. And to understand that, I want to call your attention for the following figure. It is an histological cut of the vocal folds representing several subunits, but I would like to call your attention for the following ones. The epithelium here, the superficial lamina propria, the macula flava, and the vocal ligament. And why is that? Because previous studies, particularly the later one by Kyrgyzstan et al. Published in journal Voice, have found receptors for sex steroid hormones in these vocal fold subunits for both female and male vocal folds. And these sex steroid hormones are testosterone, estrogen, and progesterone. Here, their quantity represented in these bars. The light gray fences represent the female concentrations of or amount number of these receptors, whereas the dark fences correspond to the male receptors. So if we want to summarize the results of this study, we could say that androgen and estradiol receptors are more abundant and that the macula flava and the vocal ligament are the subunits where these receptors can be found with in bigger numbers. So no wonder that changes in concentrations of sex steroid hormones affect the voice quality. Actually, if we look into the history of music, we found the voice of the castrati with that very unique timbre and long phonation time. But we also find evidence of a relationship between sex steroid hormones and voice quality in pubertal voices. For example, we know of the decrease of fundamental frequency of about 1 octave for boys and a third for girls during puberty, while the sex steroid hormonal concentrations keep rising. And this would lead to hoarseness, vocal breaks, and breathiness. And then after puberty, we see a clear vocal dimorphism between male and female vocal apparatus. If we use the female vocal apparatus as a reference, we can see that the male vocal tract is about 20% longer, the thyroid cartilage 40% bigger, the vocal folds 35% longer, and the lung volume about 55 higher in males as compared to female vocal apparatus. But if we look at sex steroid hormones, we can understand that females are more affected than males. For example, here you have a graph showing the percentage of maximum level of concentrations of both testosterone and estradiol, that is the most common estrogen in the human body, for males and females. And you can see that clearly around 50 years of age, there is this significant decrease of estradiol. So we pay attention to this phase of life that is called menopause, and is defined as the end of the reproductive life. It can occur at the mean age of 51 years old. Here you can see the stages according to the reproductive aging workshop, showing a division between perimenopause on early and late menopause and postmenopause, after menopause. You can see how these phases are different in terms of variability of cycle length. And also you have here the average age in which these phases may occur in the US female population. And what it is clear from this map is two things. First, the increased variability in the presence of a menstrual cycle and in the variability of the length of that menstrual cycle towards menopause. And another thing that we can see here is that menopause can only be defined retrospectively, because actually corresponds to 12 months consecutive 12 months without a menstrual cycle, without bleeding. And after that, women are considered to be postmenopause. So menopause corresponds only to 1 day in a female life and can only be assessed retrospectively. So it is very difficult to study and to find, but what we know is that before that, women feel an increase in symptoms such as hot flashes and night sweats. And after that, women start to feel a decrease, a sudden decrease of those symptoms as years pass by. And what about the voice? Well, previous reports show substantial changes in the mucous membranes that line the vocal tract and the muscles in the larynx associated with menopause. For example, there have been reports of vocal fold edema, of loss of vocal tonus, mucosal dryness, reduction in the production of glandular secretions, and also a muscular atrophy impairing glottal closure. Other studies have reported dystrophia observed in 90% of postmenopausal women that were non-singers. When assessing singers, we can find that 77 perceive voice changes around 50 years of age. 46% of singers report changes such as a reduction in vocal suppleness and the loss of high notes, less vocal control, and huskiness. And about 35% of these singers report vocal discomfort. So the question now is whether or to what extent self-reported vocal symptoms and direct observations in the larynx can be reflected on voice-related metric. Previous studies are indeed controversial in terms of whether there are differences or not in, for example, fundamental frequency. There are studies like Mendes-Laureano that have not found differences between fundamental frequency and harmonic to noise ratio of sustained vowels in pre as compared to postmenopausal women. And on the other hand, other studies have found differences. For example, Linville and Lindholm have found a reduction in mean fundamental and SPL of sustained vowels in post as compared with premenopausal women, and others have found a reduction in the speaking fundamental frequency in postmenopausal women with low body mass indexes compared to postmenopausal women with high body mass index using hormonal replacement therapy. So the controversial nature of these previous results and the great heterogeneity concerning study designs and the way data was collected and analyzed called for a meta-analysis to identify which voice metrics change with menopause and the extent, the magnitude of those changes. So we searched several databases with the keywords like voice, menopause, climaterium, and we found about 1,430 references, but looking deep into their titles and abstracts, actually 1,217 were identified as non-relevant, which give us 213 references that were then screened for duplicates. We found 117 duplicates, so therefore we ended up with 96 studies selected for evaluation. From these 96, unfortunately, 78 failed to meet at least one of the eligible criteria. That would be to be a full study published in English in a peer-reviewed journal, comparing pre- and postmenopausal groups, and actually containing detailed information on the characteristics of those groups. So we ended up only with 18 publications on that meet these criteria. When looking more deeply into these studies, we found that they reported about 28 voice-related parameters or assessment instruments, categorizing these parameters, we can find that the majority fall into the category of acoustic parameters, others into phonatory, others into clinically relevant, and others as patient-related outcome measures. Some of these 18 studies, of course, these are very many voice-related metrics because some of these studies combine metrics when evaluating effects of menopause. So we looked at how the data was collected and analyzing these studies, and 9 failed to include similar methods for data analysis. So we ended up with other 9, but 2 needed further clarification from their authors as to what concerns data distribution and dispersion. So at the end, we only ended up with 8 studies considered for the meta-analysis. And because the meta-analysis required at least 3 studies to be performed, we could only extract from these studies the following metrics: speaking fundamental frequency, the fundamental frequency of a sustained vowel A, jitter, shimmer, noise to harmonics ratio, and maximum phonation time. When looking at the results of the meta-analysis, we found that the significant differences between pre- and postmenopausal women were only found for these 2 metrics, speaking fundamental frequency and FO of a sustained vowel A. Here, you have a table showing which studies were included in the meta-analysis for the speaking fundamental frequency, the sample size, and their characteristics in terms of mean and standard deviations of a speaking fundamental frequency for both pre- and postmenopausal groups. And here you can see a representation of whether there were significant differences between pre- and postmenopausal groups for these studies. We can see from the 95% confidence interval that this study and that study didn't find significant differences between populations. And here you find the weight that each of these studies contributed to the overall mean difference for the speaking fundamental frequency that is here. And what we see that there was a significant difference between pre- and postmenopausal groups to what concerns speaking fundamental frequency. The postmenopausal group showing lower speaking fundamental frequency with a mean difference of 10.1 hertz that corresponds to 0.94 semitones. As to what concerns the F0 of sustained vowels, sustained vowel A, you have here the studies included in the meta-analysis, their sample characteristics for both pre- and postmenopausal women in terms of mean and standard deviations. And in the same type of graph, you can see here that the fundamental frequency for the sustained vowel A is 13.41 hertz lower in post as compared to premenopause, which represents about 1.18 semitones difference. So what can we conclude? That the menopause has a mild effect on F0. F0 decreases with menopause, but that decreases within the degree of 1 semitone, within the magnitude of 1 semitone. And we know from previous study that the just noticeable difference for mean speech of fundamental frequency in female voices is 2 semitones. So this 1 semitone difference might not be perceived in speaking, in speech. And then another thing that we can say is that the postmenopause average F0 values is between 180.78 hertz and 190.59 hertz, depending on the vocal task. But this mean, taken from the weighted mean of all studies included in the meta-analysis, is well above the cutting point for distinguishing female from male voices that has been reported as being 165 hertz. So could this mild effect of menopause on fundamental frequency reflect the limitations of primary studies included in this meta-analysis? Why? Well, it could. If we look, the fundamental frequencies decreases with age. Women at their 40s have lower fundamental frequencies as compared with women in in their 20s. So the World Health Organization recommends if we want to assess symptoms that are related with the menopause and not symptoms related with aging, to include in comparison in cross-sectional studies groups that include middle age, younger and postmenopausal women within a restricted age range. And when we look at the age range of the primary studies included in this meta-analysis, they fall within 5 to 9 standard deviations. And also they fail to include younger age groups. Also, the fundamental frequencies reported in primary studies exhibit great standard deviations. Only the study of Ferraz et al. Reported on average more than 6 times smaller standard deviation for the fundamental frequency extracted from a sustained vowel as compared to the remaining studies. And in addition, no information if participants were professional voice users or not was provided in these primary studies. So the present work set some recommendations for future research and also calls for the need of future research in this area, because the present meta-analysis was limited to 6 parameters in 8 studies. We think that possibly some other parameters than those that were included here may be more informative with respect to voice changes during menopause, and therefore should be considered to be used in many other studies, so that we achieved a sufficient number of studies to run a meta-analysis on those voice metrics as well. And finally, research in this area should perhaps consider also combinations of voice metrics that reflect more than one dimension as to what concerns acoustical, physiological, and aerodynamic aspects of voice production. So this is all. I hope you enjoyed, and thank you very much for your attention.
Thank you, dear Filipa. This is great. Some of the phrases are not well heard, but I believe in our video recording is going to be better. So if we miss through the internet connection small phrases, we shall be making an improvement in order to hear that everything properly. And as we know, this is a great challenge for everybody, scientists, medical doctors, and of course artists, to deal with these changes in the usual hormonal life. And as we also know, the treatment has to be focused to avoid as much as possible the physiological changes in the singing and artistic voice. So I would like to thank Filipa, and if somebody, Ron, you want to say something, please?
Hello, Filipa.
Hi, Ron.
Were there many studies that looked at the morphology changes of the vocal folds pre and post menopause?
There were, but the way they assess the visual observations was very difficult to compare. And in a meta-analysis, you need to have at least 3 studies and data collection so that you can compare the pre and the post-menopausal groups.
What would you say would be the best study to be done to become more sensitive to these changes?
Thank you for that question. I would say a longitudinal study assessing the same woman with herself through the 3 phases of the menopause, so perimenopause, menopause, and postmenopause.
Is that because most of those studies dealt with group averages rather than individual differences over time?
Exactly.
Well, yeah, if you do group averages with the variability among the group, you won't find anything.
Is there somebody that wanted to add comments? Yes, Dick, please.
Yeah, it brings up the therapeutic conundrum is whether or not to give estrogen to women that are going through menopause. And if you look at the laryngeal mucosa and the nasal mucosa, it's very similar to the vaginal mucosa. So if it's dry and irritated, the same will happen with the nose and with the larynx, I would expect. So irregardless of the fact that a lot of people say, well, you increase the incidence of breast cancer by treating with estrogen, I personally think that's a low risk thing. And I think these women deserve to be treated with estrogen to help them through the problems of menopause.
Yes, thank you very much. I don't know if Orietta was working with a big database about herbal medicine. I don't know if she has some comments, because no, there are several herbal treatments that, of course, sometimes is not the best treatment, but it can help, as Dick said. Orietta, do you have something to add?
Well, thank you, Virginia. Indeed, the database was focused about herbs to be used for voice problems, but it would be interesting to see if there are some herbs acting on receptors that are as good for usually for TRP and inflammation receptors. But I will check if there are any interrelations between hormonal treatments and voice treatments with herb. I may discuss with Filipa also, because I think that we should think of the individual longitudinal, the variation about one moment and the other one about sex hormones receptors, also in other points in the nose as well, and in the sexual system. But I also think that we should take care of time. I mean, a professional has a voice which must be used throughout a time of work. So maybe interesting also to see the moist or dryness before and after a tasking voice, and so we must compare many variables among them, I think.
Yes, I think this is a very interesting subject, and of course we have to focus that the singer and the actor, they have to be controlled and examined by a group, by a medical group, and also with acoustical analysis, and also of course with the singing teacher and the vocal coach, in order to see, as you have already said, to see the development of the artistic voice in the different parts of the life. So it is important that a team group has to be done in the artistic voice. And now, for example, online, it's great because we can arrange everything. Thank you very much. And if we want to discuss, John, I'll give you later on the word for the discussion. We keep now, our next presenter is our dearest Orietta Calcinoni. As you know, she is a world well-known ENT and laryngologist and specials in artistic voice. She has been working with occupational medicine, and also she has been working in an insurance medical legal problems with artistic voice. And since 1987, she is the director of the Teatro alla Scala in Milano, ENT department. And she's going to talk about a very interesting subject, because we cannot forget that the scent of your voice through the smell and taste losses can have implications in singers and players. So she is going to talk about this very interesting theme, mainly because of the COVID-19. Thank you, Orietta.
Hi, Eugenia. Nice to meet you again, and nice to meet all other colleagues in this second comment session. So let's start with sharing my computer with you and discuss the scent of your voice. Well, in Garbo's movie Grand Hotel, they say people come, people go, but we should no more give our patients the answer, oh, well, others come, others go, don't worry. Indeed, in 2004, Linda Axel and Richard Bach won the Nobel Prize for Physiology and Medicine because they recognized that the olfactory stimuli use a metric perception. And if we disrupt these metrics, we may have a distortion in our perception, indeed. And also, we know now that olfactory stimuli and breathing rhythm are linked because it seems that the spontaneous activity of the olfactory receptor neurons keep the bulbar neural network synchronized with respiration. And we are used, our singing teacher are used to tell their students, breathe in, pretending you're smelling a flower. And as we see in this beautiful picture from David Our book, we are also used to breathe out without blowing the candle. And we also smell oxygen. In our carotid body, we have receptors, olfactory receptors that may regulate and assess if we have hypoxia established. So they correct this. And we also discuss of soundscapes, of perception of auditory and olfactory stimuli in our environment, and this is very known for artists, which often discuss about the smell of stage. This smell perception or perceived distorted smell gives a sort of an expectance, difficult to be on stage. And also there is an olfactory auditory synesthesia in peripheral cortex, as well a fusion of different sensory inputs, taste, olfaction, touch, but also visual in the frontorbitary cortex. And this synesthesia may bring us to perceive to a taste because something creates a different pitch sound when we are chewing it, and we perceive with our retronasal olfaction, and we enhance or more sweetness or bitterness perception. But indeed, our taste perception is throughout the whole body. We have some 25 types of receptors in oral cavity, gut, airways, and some encephalic center neurons. And indeed, some elders recognize food because they see the color and they attribute some tasty or non-tasty ripeness or not to the food before eating it. Indeed, we have in insular cortex a singing taste because insular cortex directs interoceptive awareness, bladder and gastric fullness or distension, pain, temperature, balance, musical listening, speech rhythm, swallowing, articulation, self-awareness and social empathy, and surrounding control and our space-time localization also with selective attention, performance and anxiety. In this way, we describe a performer action. And indeed, we use some taste qualities to name singers, like Antonio Núñez Montoya, who was called El Chocolate because of his warm voice. But in opera, often bitter is poison, indeed not, because many herbs used in voice and airways phytotherapy taste bitter. And how does bitter works? Testing something bitter triggers many different reactions. Taste buds relate with laryngeal and internalized epithelium, protecting airways, while bitter receptors in the hypopharynx links with assuming or not bitter medication, but also drinks and liqueur. They may bring to alcoholic addiction. And the environment as a faucet, they trigger immune response to bacteria, and the polymorphism or T2 R38 taste receptors should relate with airways infection more or less susceptibility. And here we see that if bacteria signaling molecules arrive to beta receptors, they release nitric oxide and move cilia to expel bacteria, while glucose may hamper this mechanism. And what about artists? Airways taste receptors trigger relaxation of the smooth muscle that surrounds the bronchial wall and promote respiratory dynamics, counteracting pathologies such as bronchial asthma. And other gustatory receptors in the circulatory system favor vasodilation and therefore tissue oxygenation. And the bitter food in stomach may reduce appetite and caloric intake, avoiding obesity, avoiding abdominal distension and paradoxical contraction of the diaphragm, but also fighting the metabolic syndrome. So in this paper, we did not know that in symptoms in this pandemic there was anosmia, but this was one of the first papers in the world from a colleague in South Lombardy describing in his patient this symptom. And there are now many papers that start from the fact that ACE2 receptors, the entrance door for SARS-CoV-2 in our body, is widespread. And if we, in this letter to the editor, Weira discussed that SARS-CoV-2 receptors are expressed diffusely on the mucous membrane of the entire oral cavity, particularly on the tongue, and in MERS, coronavirus bind to the sialic acid receptors, and this might associate with an increase in gustatory threshold. But about anosmia, SE2 is in the nasal mucosa as well, but the target of the virus may not be the neurons, the olfactory neurons, but other non-neuronal cells. And so further involvement of stem cells could be the basis of a long-lasting olfactory dysfunction. But on March 17, started a consortium of the most important centers about smell and taste and kinesthesis, and they created some surveys, and they get us some 50,000 responses in different languages. And you see how they progress from April 27 to November 28. And here we know that now we know that smell loss in COVID is very high, very intense, but in many cases, some 40% of cases rapidly recovering, while we do not know how long persistent yet, because it's a too short period since it started. And we are discussing which treatment best. Well, I will invite you to this webinar. You may become a member of the GCCR, or call me or write me if you want, which will discuss which treatment shows better results. And so, ending with another famous movie, Gone with the Wind, they say that Clark Gable was eating garlic because love scenes with Vivian Leigh, they were not so polite to each other, and so maybe that sometimes for actresses anosmia would not be that bad. Thank you.
Well, this has been a great approach to some of the senses that we are a little bit far away from them. As we know, they are very primitive senses, but now with COVID and with many other viral and bacterial infections, we do know, and of course respiratory allergies, we do know that the olfactory sense is very important for everybody. And as we know, the biofeedback is also very important. Orietta, I don't know if you want to comment a little more about this research. And I think this is a great opportunity also that we can change a little bit our idea of having the complete brain system in the artistic voice. I mean, the complete brain system organization through the different senses, even though these are, like, as we know, small senses. Please, Orietta.
Pardon? I missed you. Sorry.
Oh,
I
it's
missed
okay. No, I just wanted to ask you if you have some more comments to your work or to the or to your experience, because as we know, in Lombardy were the first cases known with olfactory and taste problems in COVID time. I don't know if you have more to add with your daily experience with this kind of patients and in artistic voice.
Yeah, yes, indeed. Now there are a lot of patients claiming for that, but I think that many of us in February or as soon as the pandemic arrived in their country, we were accustomed to see smell and taste losses in our patients because of many viral problems, or also allergy or trauma, and so I myself at first in late February in the first case is claiming, oh, I'm not smelling anymore, or so I said, well, take some decongestant and something might be just a cold, but we saw such many people all together claiming the same thing, and up to date we are not it looks like the virus is trying which way it may come in, because some people claim smell losses and taste and or taste losses as soon as, and maybe the only symptom they claim, but others and so at first we started with the survey in early April, the one you see the graph, which is in the GCCR, and they were only aiming to people having some respiratory illnesses from COVID, and then developed some smell and taste losses. But now we see that it's a mess. In someone started before, in someone comes during the respiratory illness, some other have a short respiratory illness, and after, when they regain health, then starts a new sensory loss when they think well, I'm out, well, I'm healthy, and they see this, and now the problem now is that in some sort of mark of infamy, you can't have a smell loss because your friends are afraid of you, and some people ask, how can I hide this? How can I behave like I taste or smell the same? It's a problem we must cope with, also for professionals, because nowadays professionals are so cast away, and they want to be back on scene or a project, and so, and this also, if it's a small thing and we say, well, much better than stay in a ICU or so, but maybe hampering. So we must keep some solutions for them, how to cope.
Thank you, dear Orietta. I don't know if somebody from the audience wants to add something or to ask something. For example, Professor Jürgen Bender. Yes, John Rubin, Peter Hulin, Iris, if somebody wants to add something from COVID or not. Well, what I want to add is what kind of treatment can we do to these patients that have olfactory and taste problems? I don't know if in the world has been used gabapentin or some of the anti-neural inflammation drugs. John, Erki, Ilter, Adi, somebody, Joseph, Isabel, somebody has experience about treatment in this kind of problems? Not yet. So we shall discuss next year. So if somebody wants to ask to Orietta about this interesting survey, and presentation? No? And I want to thank also Rocío Pérez Caballero and Alejandro Armenta that they are sharing with us this session. And if I miss somebody, please let me know. And well, as closing remarks of this third session, I am very grateful for the 3 presentations. They are very interesting. Neurogenic lesions are also well known in the viral infections, as Isabel García López said. And what about menopause? It's a very interesting subject. And also, as Dick Stasny said, well, we have to think about the treatment with estrogen, even though there are many controversies. And about this new field of the global research in olfactory and taste problems, let's give them also the opportunity and say to our patients that they have to answer this survey. And I want to thank you all for your presentations and for your presence. And as we know, we are having, I hope you have received already your invitation for the celebrations next Saturday. So you are very welcome to make a 2 minutes presentation if you want to say something from your country, from yourself, to say hello to everybody, or only to stay online like we do today. The thing is to have a celebration and to have your favorite drink. For example, I'm going to have tequila. This is next Saturday also. And we are going to say hello to everybody. Everybody is invited. And also our next presentation in the 4th academic session will be 30th of January. And this will be our masterclass tribute to Francisco Araiza. This is a great tenor, as you already know. And he has worked with some of the most wonderful directors like Herbert von Karajan, Ricardo Muti, and many Daniel Barenboim, and many others. And so we are going to have this interactive masterclass with him, and also as a tribute because he has celebrated, and it was in Germany, Austria, and Switzerland that they made special celebrations to Francisco Araiza because of his 70th anniversary. And we want to say you that in our Collegium Medicorum Theatri Congress in Leeds, England, the British Boys Association is almost deciding to have an online congress and also with streaming. So we shall let you know next Saturday what is our decision. But as we see, this is a great opportunity to meet everybody online and to have schedules, everything. And we miss our dear colleagues from Japan and China. And I hope they are going to be here with us very soon with Shigeru and Hirome and other persons. We miss many of our dear friends, but we do know that they cannot be with us all the time. And of course, as you know, in our CoMeT webpage, there are the sessions and the videos that you can see all the time with the acceptance of our presenters in order to publish that in our YouTube channel. It's very nice to see you, and as always, you may stay with us to have more discussion. So I thank you again very, very much. And if you cannot come, please send a video or a photo for our celebration online on 19th of December. And I wish you many dear celebrations. We have to fight against SARS-CoV-2 and keep safe and stay at home. And dear kisses.